Hi, this is Dr. Alemi with a brief lecture on the impact of computerized physician order entry on quality of care. If you look around, when the computerized physician order entry was first introduced, there were lots and lots of complaints from physicians. Here is a typical response. If we go to a system like this and begin to implement it, we may not be drowning in paper every day, but if we can't get enough work done, and if we can't see enough patients in a reasonable amount of time to be able to generate the revenues that will support our office, then that could be a disaster. The central concern with computerized physician order entry is that it will require more time than paper records. It will take longer to take care of the same patient. In other words, that it's inefficient. There is also concerns that it may interfere with the patient care. Here is a host of other concerns that physicians from time to time have expressed. That it may be used for pay-for-performance, that it violates antitrust, that it's not private and secure, that exposes the physician to liability, and that it lacks interoperability. Let us focus on the central problem why physicians do not like computerized physician order entry. Part of the worry is that maintaining both a paper and an electronic record will double the cost. Physicians are concerned about effort. They ask, will it let me do what I am doing? Do I have to spend more time at it? I'm not a typist. Will I have to redo things? Is it fast? Of course, they do not see the time saved because records are available on demand. They care about their own time, and they're worried about their own effort. Let us see how much more time will it take to complete a medical record using computerized physician order entry. In 1994, it took twice as long. In 2001, it went down to 5% more. And in 2006, there was no difference. It used to take a lot more time, but recent studies show that there is no difference between physicians entering the information in paper or on computers. The use of computerized physician order entry in hospitals is growing and is expected to be nearly in every hospital in the next few years. In some areas, 80% of urban hospitals use computerized physician order entry. The delay in implementation is primarily in rural hospitals, small and non-teaching hospitals. There is a big difference in modern computerized physician order entry systems. Earlier systems had poor ratings. Here we see on a scale with adjectives like wonderful, easy, satisfying, adequate, power, stimulating. Earlier systems being rated systematically worse. Later system, newer system, are being rated a lot higher. The impact on quality is a lot more complex than first imagined. One expects impact on medication errors, reduce adverse sentinel events, reduce liability with use of guidelines, and reduce waste and duplicate testing. There is a delay in information flow from hospital to general practice, and remote access could reduce the delay and therefore reduce the duplicate testing. Because of improved exchanges among physicians, pharmacists, and nurses, one expects fewer errors. In this study, done at baseline and at 3 other periods, we see the rate of patient days in which there were errors. Surprisingly, there is little improvement in the early months. In the first 5 months, there is almost no radical improvement. When allergy warning system is added, the situation changes. and drug-drug interaction systems are implemented, then better results are observed. And we see now radical changes in rate of medication errors. The point is that just storing and retrieving data is not much of a benefit. To get more out of your investment, the physician needs to analyze and use this stored data. Things like drug-drug interaction is an example of that. Here is another study showing that the portion of cases with medication errors goes up after implementation, but is reduced once drug-drug alerts are implemented. Why should errors go down? Before the implementation of electronic health record, the process of care and transitions from one provider to another is quite complex. Paper is shuffled throughout the organization, and sudden changes in orders often fail to make it in time before medication is administered. EHR, electronic health record, streamline the process and reduce sources of error. After electronic health records, all parties are instantaneously aware of any changes in orders. Simple and straightforward. The reality, of course, is that you get what you put in. If healthcare managers look at IT as a quality improvement opportunity, then electronic health records and computerized physician order entry is likely to lead to improvements. Stay involved. Make sure that you make the decisions about the vendor, components included, and configuration of the electronic health record in ways that affect quality. In the end, you get what you want it to be. If you want a system that improves quality and does not affect efficiency, you can have that. If you do not want to sweat these things out, then you won't have the impact on quality. The likely impact depends on you and the details of what you plan.